I hope you're all well fed and watered, caffeinated.
Yeah. Hi, everyone. I'd be grateful if you could all take a seat, please. We are raring to go for the afternoon session. Okay, let me start by introducing Nicholas Jex. He is going to do a clinical case presentation on a patient with refractory angina with diabetes and hypertrophic cardiomyopathy.
Okay, thank you very much again. Pleasure to be here. So, as I say, my name's Nick Jex, I'm cardiology registrar from the Leeds General Infirmary, and I'd like to just run through a case of refractory angina in a patient with diabetes and apical HCM. So our patient's a 59-year-old gentleman who has combined HCM and an apical phenotype of HCM, and he was seen over an 11-year period with a significant burden of anginal chest pain, which was refractory to standard therapy and persisted on ongoing follow-up. And I hope that the sort of insight that this case can provide for you is that we had the benefit of serial coronary imaging and serial CMR imaging over an extended follow-up period. What we saw in this case was that a significant decline in coronary microvascular function despite unobstructed epicardial coronary arteries. So our patient first presented in 2010 at the age of 49 to hospital with troponin-negative chest pain. He had an elevated BMI, but clinical examination was otherwise unremarkable. Background of essential hypertension, stroke and obstructive sleep apnea, but no family history of cardiomyopathy or sudden cardiac death. And he was subsequently diagnosed with diabetes in 2015, and he was a lifelong non-smoker. This is his admission ECG, showing characteristic anterolateral T-wave inversion, which you see in apical HCM. Unsurprisingly, given his presentation with chest pain, the initial primary differential diagnosis was acute coronary syndrome. But his baseline coronary angiography in 2010 showed unobstructed coronary arteries. So as I said, however, so in addition to his ECG and angiography, he had an echo which was suggestive of apical LVH without any presence of outflow tract obstruction. So here you see his cardiac MRI, which confirms the suspicion of the echo with an apical HCM with significant hypertrophy, and you'll note his body habitus from the MRI as well. So as we said, the cardiac MRI confirmed the findings of apical HCM. He had a baseline ambulatory ECG, which showed sinus rhythm without the presence of AF or non-sustained VT. He had a negative 21 gene panel, and at this point his ESC risk score was low at 1.76%. As we said, this patient had significant morbidity over an 11-year follow-up period with significant anginal chest pain. And this was refractory to standard therapy with calcium channel blockers, beta blockers, nitrates, and ranolazine. And he required a total of 4 hospital admissions to acute cardiology services due to episodes of chest pain at rest with elevated but non-dynamic troponin changes. And over the follow-up period, his diabetes control was persistently suboptimal. So because he kept presenting with chest pain, he got a series of coronary angiograms and a CT coronary angiogram in 2021, which showed, despite having multiple atherosclerotic risk factors, he didn't develop any obstructive epicardial coronary atheroma. And again, because of his ongoing symptoms, we had the benefit of serial MRI imaging between 2010 and 2019. And what we saw over this period is that although he didn't have obstructed epicardial coronary arteries, we saw a significant decline in his myocardial perfusion and coronary microvascular function, suggesting that this is the cause of his ongoing symptoms of chest pain. So here you'll see his quantitative perfusion map. So just to orientate you, this is a short axis view of the left ventricle. And if you look at the basal segment, which is not, non-hypertrophied, this is showing nice normal perfusion, which you can see by the sort of orange colours on the scale. But if you move into the mid and apical segments where affected by hypertrophy, you see significant global perfusion defect suggestive of microvascular dysfunction. We also saw a significant increase in his myocardial scar burden on late gadolinium enhanced imaging, which increased from 6% in 2010 to 40% of his myocardium in 2019. And this was despite relatively modest increases in his apical LV maximal wall thickness. So just to summarise the changes in MRI findings and the natural history over the follow-up period, so between that first MRI in 2010 and the latest one in 2019, what we saw was relatively modest changes in LV ejection fraction and wall thickness, but a significant increase in myocardial scar, which was mirrored by a significant deterioration in his myocardial perfusion and a decline in global longitudinal strain. So he had a further admission in June 2021 with chest pain, and at this point, a period of telemetry showed an episode of non-sustained VT. And with this, his ESC risk score increased to 3.35%, and he was commenced on an SGLT2 inhibitor because of his poor diabetic control. Because of the evidence of non-sustained VT and the quite significant scar on his MRI, the AICC MDT considered whether he should have an ICD implanted, but it was felt, given that his ESC risk score remained below 5%, that there wasn't really a clear mandate to offer this. So just to discuss, so we know that the apical variant of HCM occurs more commonly in the type 2 diabetes population. We don't really fully understand the reasons for this. Both these conditions are associated with coronary microvascular dysfunction. Hopefully this case gives us some insight into the natural history of these conditions with serial perfusion imaging over an extended follow-up period. So as we said, so perfusion defects have been shown to be a nearly universal feature of apical HCM. There's some interesting work done by Bart's group recently which showed nearly all patients have these perfusion defects on quantitative perfusion. And so when you get the added hit to the myocardium of type 2 diabetes, which is also associated with microvascular dysfunction, there's a potential for a significant impact in terms of microvascular angina and symptoms. So potentially there's a need for further evidence-based treatments in this set of patients. So we know that we get myocardial scar in around 46% of patients with apical HCM. In our case, we saw quite a significant increase in scar burden from 6 to 40% over 9 years with subsequent evidence of non-sustained VT. Despite this, our patients' ESC risk score remain low, below 5%. So whether there's a potential pitfall in the use of this risk stratification tool in this subset of patients. So to summarise, hopefully I've emphasised the importance of coronary microvascular dysfunction in apical HCM, particularly when you get the additional hit from type 2 diabetes or other cardiometabolic comorbidities. We've reviewed the potential natural history of these two conditions over a period and also shown you the significant impact myocardial scar can have despite a low ESC risk score. Thank you very much for your attention.
Thank you very much. Any quick questions whilst we switch over? And Stefania, if you'd like to come up just whilst we switch over, any questions? Can I ask one quickly, Nick, about, so you mentioned using the SGLT2 antagonists in the context of his diabetes. What are your thoughts on the implications for apical or obstructive HCM in that context, given the diuretic effects of SGLT2 antagonists? Yeah,
I think the patient didn't have obstruction, so I think hopefully it would be relatively well tolerated. I think there's some potential that they've been shown to benefit in terms of sort of myocardial sort of energetics and metabolism, so there may be a potential role there. Something like use of the GLP-1RA inhibitors may have a more beneficial impact in terms of perfusion, so I think that might be, maybe for this subset of patients, might be better treatment.
Thank you very much.
All right, thank you.
So I have a pleasure of introducing Stefania Rosmini. She's a consultant cardiologist at King's and specialised in CMR and inherited conditions. Thank you.
Thank you, Alice. It's a pleasure to be here. This is a case that we shared with the AICC team, Guys and St. Thomas's. Is a young lady. She presents end of 2021. She has no significant past medical history, no cardiovascular risk factor except from smoking and occasional cannabis. She reports no family history of cardiomyopathy or sudden cardiac death. She's not on any regular medication, has never received a COVID vaccination, and there's no history of recent vaccination. She presents a local ED with symptoms of palpitation, shortness of breath, and chest tightness. This after smoking cannabis. There's an episode of vomiting with this, but she's afebrile with no inflammatory or flu-like symptoms. Her ECG locally shows a still elevation in inferolateral leads. Therefore, in the suspicion of an acute coronary syndrome, she's transferred to King's Cath Lab. her angio is normal with smooth unobstructed coronaries. An ECG with us subsequently show actually more diffuse ST elevation anterolateral inferior leads. The troponin is significantly raised, peaks at 7,500. White cell count are normal, in particular normal eosinophilic count throughout the admission. There is a borderline, very mildly raised CRP only, with normal ESR and ferritin. CK is significantly raised as the NT-proBNP. Autoimmune screen is negative, ACE is negative, and an extensive viral screen is negative, including COVID-19 RNA. This is a echo. The ventricle is not dilated, LV non-dilated, with global moderate impairment. The inferior inferolateral walls are more hypokinetic. Ejection fraction is around 40%. At this point, the query is of myocarditis, and she's referred for cardiac MRI. In CCU, she's hypotensive, and there are runs of non-sustained VT documented on telemetry. The morning after the admission, she comes for MRI. Here, just a snapshot of the extracardiac anatomy. She has a high BMI, but there are no pathological lymph nodes or no parenchymal lung changes of note. Here, the long axis. Again, the ventricle is non-dilated, globally moderately impaired function, more pronounced lateral walls, inferior walls, and the walls are thickened. There's a relative LVH in here. LVH, ejection fraction is moderately impaired, 37%. Here, the short axis view. Again, we notice she's a young lady, relative LVH, although maximal wall thickness is still within normal limits. Then we go to pre-contrast tissue characterization. Here, T1 mapping, long axis, we see diffuse patchy enhancement of T1, inferoseptum, inferior wall, anteriorly, anteroseptum, here the short axis from basal segments, all of this patchy area down there. Here on the right-hand side, our normal T1 map would look like, and for our patient values are significantly raised. T2 mapping for edema and inflammation is even more concerning. Very high signal throughout the myocardium, anterior wall, inferior wall, septum, from base to apical segments. Again, on the right-hand side, our normal T2 map would look like, and for our patient values are significantly raised throughout. Leg gadolinium enhancement, there's no need for a description, it's a scary image. There is a non-ischemic subepicardial mid-wall reaching transmurality in several points throughout the myocardium, from basal to apical segments. Short axis show a very clear circumferential pattern sparing the endocardium with RV involvement. At this point, the aim is to get an endomyocardial biopsy as soon as possible. She's having non-sustained VT on the scanner. My differential at the point are a giant cell myocarditis, she's hypotensive, non-sustained VT, and this terrible MRI. Obviously LVC because of the circumferential LG, and sarcoid as a granulomatous inflammatory condition. She was started already on our medication. The biopsy cannot happen on the day, so she started on IV methylpred as inflammatory markers are negative, symptoms not in keeping, and infective screen is negative. A more in-depth anamnesis actually reveals that for 8 days prior to the admission, she had been taking an unlicensed pill in order to lose weight that she had discovered on Snapchat, and this was together with a program of a high physical exercise with someone who had been so far relatively sedentary. She developed then profound tiredness soon after starting the pill with acute breathlessness, palpitation, and dizziness, which is what brought her to seek for medical attention. This pill contains a lot of overall natural ingredients, in particular this Garcinia cambogia, which is a tropical fruit and a popular weight loss supplement. It's considered unsafe from the FDA due to the risk of liver toxicity. We did find, looking up in the literature, a couple of cases of acute necrotizing eosinophilic myocarditis in this patient, with taking Garcinia. So the endomyocardial biopsy happens the day after the MRI. It is successful. We get 7 myocardial samples from the RV septum, and we remember that from the MRI, both on T2 and LGE, there was RV involvement. The biopsy shows a focal myocyte necrosis with occasional interstitial lymphocyte, but doesn't reach criteria for a lymphocytic myocarditis. There is minimal interstitial fibrosis. There are no giant cells, no eosinophils, neutrophils, or granulomas. The patient is asymptomatic at this point. Troponin is downtrending. She's discharged home on optimized heart failure medication and tapering oral steroids, and with a planned outpatient follow-up in 3 weeks in the myocarditis clinic with an outpatient CT PET to further investigate for sarcoid. I am though worried. At this point, some of you have recognized the images already because I discussed this case at London CMR. I'm a bit worried. I'm waiting following the results of the meeting. I call her prior, and she reports that she's again experiencing frequent palpitations. So I organize an urgent Holter, and the Holter shows frequent polymorphic VEs with ventricular tachycardia. I asked her to come back to hospital. She's started on amiodarone, and she has a PET at this point that shows no active extracardiac sarcoid or large vessel vasculitis. There's a low grade of myocardial uptake in keeping with the degree of inflammation. At this point, we have referred her to the AICC team, and here is mainly Liz, our lead AICC nurse, who sees her. The patient is really not compliant with the medical therapy from our side, doesn't attend for follow-up once she has discontinued the amiodarone. She does come for follow-up imaging, and we keep her under close observation. Whilst an inpatient Lisa sees her, it's a difficult approach to the patient during this is the second admission. There is an initial discussion of a possible underlying genetic condition. She's very suspicious. She refused a family screening to get the family involved, and once asked the possibility for DNA storage, she declines that too. She does come back for a follow-up at 1 year. Here we see that the ventricle has now mildly dilated, thinned out. Ejection fraction hasn't really much changed, still 39%. We can see globally more pronounced and inferiorly at the lateral walls. RV function is fine. There are no obvious abnormalities in the RV. Here is the T2 map, still 1 year from the initial event. There are still areas of high T2. This point close to the MRI, troponin is normal. And the LG is typical, as we've seen, thinned out, but circumferential diffuse LG mid-wall subepicardial. We discussed together at the AICC the phenotype, MDT, the phenotype. There is agreement that the phenotype is most consistent with an arrhythmogenic cardiomyopathy, that genetic testing and family screening should be considered, and there's a recommendation for an ICD in view of the severity of the LG enhancement. Patient is really difficult engagement, doesn't attend, despite being clearly traumatized from this. She refuses psychological support and doesn't want to talk to family about the diagnosis. Though following the MRI, I really think she was hoping, obviously, in an improvement in the cardiac function. She accepted to have genetic testing done, and this shows a frame shift pathogenic mutation in the SP gene, predicting to cause premature protein truncation, leading to loss of function. So just to summarize, here is a case of a young lady that presents with a very severe acute myocarditis. This was triggered by a diet pill associated by physical exercise in someone with a positive genotype for arrhythmogenic cardiomyopathy. This confirmed the concept that positive genotype can remain asymptomatic until a hit comes in and triggers the phenotypic expression. We know about physical exercise, but in here clearly this diet pill triggered such a severe presentation and especially MRI findings. Thank you.
Thank you very much, Stefania. I mean, I get that case very much illustrates the overlap that we see in hot phases of disease, and also the very characteristic ring-like pattern that is commonly associated with desmoplakin. And DSP is the top cause of that phenotype, really.
Certainly, so such a T2 image is an edema I hadn't seen before.
Any questions from the floor? No? Okay, fantastic. Thank you very much, Stefania.